Hi, my name is Patrick Emedom-Nnamdi, and I'm a current third-year PhD student studying biostatistics at Harvard. Today I'll be presenting on some joint work between Dr. Timothy Smith's group at the Brigham Women's Hospital and members of the Onnela lab at the Harvard T.H. Chan School of Public Health. The title of this talk is Pain Level Prediction in Neurosurgical Spine Patients Using Digital Phenotyping. It's quite crucial for medical providers and physicians to have access to methods that can objectively evaluate a patient's health and detect for possible complications after a medical intervention such as a surgery. Patient-reported outcome measures, or PROMs, have been widely used to fulfill this goal. However, these metrics are dependent on patient recall and at times fail to accurately capture a patient's quality of life. Fortunately, digital phenotyping provides a means for researchers to passively collect behavioral data as well as metrics typically asked for on PROMs, such as daily self-reported pain levels. Hence, the goal of our current work is to bridge the gap between PROMs and digital phenotyping by building a model that can accurately predict self-reported pain levels using features that capture a patient's mobility and physical activity. Our data is comprised of a subset of the much larger spine disease cohort over at the Brigham Women's Hospital. This subset consists of 174 patients, adult patients, with a mean follow-up of 78.5 days. The enrollment period for these patients was from June 2016 to December 2019. Furthermore, patients within this subset were clinically diagnosed for spine disease, with 41.3% having undergone a neurosurgical intervention. For our digital phenotyping data collection, we utilize the BWH research platform to actively collect daily self-reported pain levels from surveys that were administered on a daily level. For our analysis, we specifically focus on the data that we passively collected from the accelerometer and GPS sensors. Using these data streams, we were able to further characterize patient mobility and physical activity using a number of the summary statistics that I've listed below. Next, I'll present on some initial results. Our prediction model consisted of a 3-layer neural network that we used for classification. Our response variable was a reconstructed daily pain score with 3 levels that coded for low pain, moderate pain, and high pain. The mobility features that were included were maximum distance traveled, time spent at home, total distance, and entropy. Additionally, each of these feature values were summarized on a daily level. Our training set consisted of 80% of our original data, or more specifically, 5,992 patient days. Furthermore, we performed our hyperparameter tuning for our neural network using a random search grid. In general, our model was able to obtain an accuracy of 79%, with a mean average precision of 71% on this current split of data. In conclusion, our initial neural network model showcased its ability to discriminate between varying levels of pain scores using mobility features sampled from smartphones. Our current direction focuses on determining an appropriate method to deal with the variability seen when understanding how patients report their pain. In general, an effective pain level prediction model will provide us with a tool to help current research surrounding determining intervention strategies that can help improve postoperative recovery, estimating patient recovery strategies after a surgical event, and in general, assessing patient quality of life. I would like to thank members of Dr. Timothy Smith's group and the Onnela lab for their efforts in preparing the data for our project. Thank you.